So, you know, one consideration is we do sell this flexible foot. If that would be helpful to you, you can purchase it on our website. Separately, we have a cheaper version which you can buy for $20. Now, the cheaper version doesn't have, it has wire, so it has some mobility, not as nice as the elastic, it's not finished and all that stuff, but you know, you can have the Cadillac for $125 and it comes on a walnut base, okay? Or you can get this 4th grade, you can still see the lines from the molding and all this stuff, you know, and sometimes the color doesn't even match on the plastic, but that's 20, that's 125. If it's helpful to you, you can buy it. All right, so we were talking about the cuboid, and you really want to make sure that your contact is on the medial part of it. So you come off the metatarsal head and fall into the cuboid, and then put your finger there, and you want to be on even the most medial part of that finger. Okay, so you'll clasp it like this. You've already prepped the midfoot, so then you're bringing cuboid up and down, emphasizing the down, up and down firmly, and then progressively you kind of just whip medially, whip medial. So it's up and down with a whip, up and down with a whip. You're progressively getting the cuboid to rotate medially and come downward and get seated. Okay? So, after you accomplish that, you should be able to grasp that cuboid from beneath, and it's, you know, don't stress, you'll find it. That's the only thing that's under there. If you're under there, you're on the cuboid, I promise you. It's not, you know, don't get hung up on, am I there, am I not? Don't. You're there, I promise you. So you can test your up and down mobility there, and you'll be able to discern a difference. After that, all of that leads to the big important joint. Now there are some individuals who actually need specific mobilization on the cuneiforms, or you know, especially the medial one, but that's extremely rare. You did not have that restriction, but it's similar to what you did to the navicular. You can come and work on rotation. That medial one rotates much more so than the other two. The other two are more like blocks that just go up and down or kind of shift over. So whatever you did at the navicular, you could come up 1 thumb width and then work on that more anterior part of the midfoot. Okay? So that's a little interjection there. So this all brings us to working at the complicated subtalar, incredibly complex joint. And it is just, you know, crazy, you know, dips and grooves and such. Extremely complex joint, but easy to treat if you understand it. Here's the deal. Your foot was stuck in varus, right? You remember the video where this was lined up like this and it was parallel to the other foot. And I could not push it here into valgus. On the bottom of the heel goes outward to the right. The secret is that if you try and move it into valgus, you just jam the lateral facet. You need to distract the joint and you twist it to the left, okay? And believe it or not, part of valgus includes the rotation. So I'm doing 2 things here. I'm making the heel go outward to the right, which is called valgus or eversion, but I'm also twisting it to the left. So those are combined motions. And it's just gorgeous to see how it's designed for both of those things. And a lot of clinicians just measure the varus and valgus because it's much easier to measure than measure with a goniometer the transverse plane rotation. So unfortunately, maybe for that reason, they don't realize it's treatable. Oftentimes that other thing leads to unorthotic or exercise or something, but the MOB is very effective and it's very, very specific. What you do is you use a web space of your hand and you distract the heel inferiorly. Okay, so you're trying to go that way, but guess what? There's all this Achilles tendon up here. So actually the best you can do is push it at a 45-degree angle. That's okay, because half of the vector is inferior. Now if you have the luxury of someone helping you, then you have them do that at a 45, but they also come with their other hand and grab the midfoot. and they pull them both, you know, inferiorly together. Okay, so it looks like this contact here, and that one comes inferiorly, you know, towards my elbow. Okay, and then this one, by the nature of the anatomy, you can't get on top of it, therefore you end up pushing the heel at a 45, but together they do magic. Okay, you do that hold for 30 seconds. You can, again, you can treat yourself if you don't have someone who can reach over and grab the forefoot. I'll have to play and see if I can do both to myself. I don't think I can. If you're treating yourself, you capture it like this, and you distract it for 45 seconds. Okay? Then you do the twisting thing. And don't worry about the eversion, it happens automatically. So then you twist the heel to the left. So the back of the heel goes to the left towards the midline, okay? And so the front of that calcaneus and the front of the foot goes to the right. That's called abduction. It's a strange terminology, but that's what it is. Okay? So you don't go back and forth. You take up the slack in the structure to end range, and you do 30 oscillations at that point, still taking up the slack. Okay? That is the self-treatment. So let me now take it into how would you treat yourself? What would that look like? So let me create a little bit of space here, and I will take my sock off and show you how easy it is. Much nicer if someone else can help you, but it can be done. All right? So we talked about mobilizing the talus posteriorly. If you have to treat yourself, you just pull back like this, really firmly, 30 times. And I'm using like all of my body weight. My whole body is bouncing back, okay? But you try and take up the slack. And because the heel is on the ground, it's on this bed, because the heel is fixed, that's the same thing as someone pulling the heel forward. Still works. And then you come up a ½ inch or so onto the tibia, and you do the same drill. Okay? After that, then you lay with your knee sideways like this, and you come under the heel, and you sincerely can feel if there is a little bit of play, and there is. I can get the tiniest little bounce. First I lean into it and take away available motion, just mild to moderate force, and I can spring it. I don't need to treat it. But if yours was tight, then you could lean on it for 2 minutes, or you could oscillate 30 times, or a combination thereof. Okay? After that, you just slide over to the front of it, and you're asking yourself, can I push it posteriorly, take up all the movement in the foot, okay, and now can I get little oscillations? The answer is yes. So then you would come behind it. Can I take up the slack, pushing it forward? And the answer is yes. Yes, I can create movement through that structure. Therefore, I'm not going to treat it. I'm going to choose to then move up to the fibular head. And so, it's right here. So it's a couple fingers below your knee. Okay, on the lateral surface. You'll feel it's a little bony bump. So if I push it towards the floor and a little bit laterally, remember the 20-degree angle, push it down and lateral, can I then do repeat little bounces? And the answer is yes. Okay? So then I'm going to lay like this, okay, ideally with the foot off the edge, and you find the back of it, and it has there's much more area, surface area for you, so you can use the heel of your hand. So you take up the slack through the whole structure. Some of your hip moves, some of your foot moves, it's okay. Then you finally take up the slack in that fibular head. Can I give it little bounces and have it move through that structure to where my foot moves a little bit, my thigh, bounces a little bit, and the answer is yes. Okay, otherwise you would stay on that for 2 minutes. Never hurts to do 30 little oscillations. okay? On a rare occasion, that fibula can get stuck upwards, and hiking can do that. My son had that injury. It's the opposite pattern in which you get an eversion injury and you test it for, you know, for inferior mobility. And I rather doubt you have that, but, you know, if you did, you would find that you would not be able to create that spring mobility going inferiorly, and there would not have been any upward mobility. And when you try to restore the upward mobility, you would have failed, okay? So in that case, the goal is to bring that fibula down, okay? But that is honestly the exact opposite of the injury you presented with, so let's get back on track on what you presented with. So after we've worked the fibula, then you're going to work on midfoot, okay? A little tricky for a single person job, you know, but it can be done. So you just come and capture this part, you know, just slide down to where you stop moving. The vicula is there, it's that prominent little critter, and probably easiest to capture it with your thumb. You do want the foot really relaxed. And it's not as nice as someone else doing it with you, but this is how you self-treat it, okay? So you work on that 30 times, and we're emphasizing the rotation only. It's a little hard to do the inferior glide. You do want to push a little bit forward for some distraction for a little while, and keep that distraction, and then work on the rotation, okay? You can then capture it with two hands and do the distraction towards the toes for a little bit, and then you can push down like this. So you're trying to get the dropping of it, the inferior mobility. Not as nice as someone else with two hands working on you, but that is how you would self-treat it. And then, to capture navicular, wrong, cuboid. You come along the outside border, the fifth metatarsal, and then you fall into the depression, and then you want to come one finger's width above that, okay? So you want to come here. And you want to be very relaxed, and you just test inferior mobility, and we'll stop here and have a third film.